And so now we're going to turn to the question and answer portion of this presentation. We've gotten a lot of questions already, but if you haven't asked a question yet and you have one, feel free to enter it in the chat and we'll go through these questions. Also, so one thing that I want to ask the group is, the whole audience, is what kind of ideas you have for improving the doctor-patient relationship. So we've heard a lot of things, both from the doctor side of things, as well as the patient and the family. And if you have any thoughts for what could be done to improve this, we'd love to hear them. And also, if you have things that you or your doctor have done that have fostered a successful partnership, we'd love to hear those too. So feel free to put those comments in the chat, and I'll just put these questions in here. So that you guys can have them to look at. All right, there we go. Okay, so we have a lot of questions. Let's see. I think one of the questions that came up is that what kind of advice, this could be for Dr. Azola, or this could be for Dave and Sue, but you know, what can patients do when they aren't able to just go from doctor to doctor to doctor? You know, they might find a few doctors that have not listened to them or aren't getting them the help they need. And what should people in that situation do, especially those who are, you know, maybe they're on Medicare and they have fewer options, or they have just so little energy that it's difficult to go just select new doctors all the time?
Yeah. I just want to speak a little bit about access to medical care. It's definitely an issue in our current medical system. Insurances restrict which physicians you can visit, or you know, what locations. It's just very, there's a lot of barriers to access to medical care, particularly for specialized access to people with understanding of certain chronic disorders. So my hope is that this pandemic will open doors to educating patients that have chronic illnesses. I think that it's going to open up access by increasing the number of providers that are going to feel comfortable treating this. I personally think that, for example, the Academy of Physical Medicine and Rehabilitation has been taking an active role in spearheading education for other providers, creating consensus guidelines, learning from providers that have been treating these disorders for longer. And I think that that's going to improve patient access. But I definitely think that part of it is the medical system that we have in place. But another part is the limited amount of physicians that are trained or understand how to manage this patient. So hopefully one of the things that will come from the pandemic will be expanding that footprint.
Thank you. I think one other question that has come up a lot is that really right now the onus seems to be on the patient a lot of times to be educating the doctor about what is ME, what are the symptoms, that it's not psychological. So do you have any advice on how that could be changed so that it's not just, the burden isn't just on the patient to be bringing that information with them and trying to persuade the doctor?
In terms of whether it's something psychological, like that they think the root of it is psychological? Is that...
or just that, you know, how can we, do you have any thoughts on how this can be changed so that doctors are learning about it in other ways, so that they know about it already when the patient comes in there, the patient doesn't have to introduce this disease to them each time they have a new doctor?
So that's going to take a more... So basically, we don't get taught about ME/CFS in medical school. It's not part of the curriculum. Again, I'm hopeful that highlighting with this new surge of patients with this disorder, that's going to highlight the importance of educating the clinicians. We know that most of the primary care physicians are going to be receiving these patients, and we need to educate them. So I think that we're already starting to create documents, and there's echo projects that we're using to educate other primary care physicians and outreach. However, I think hopefully it'll lead to a change in the exposure, an earlier exposure to physicians regarding this conditions. But there's a lot of ground to be covered in order for that to happen.
I feel like there's also one thing that I found surprised in, I think it was just at our last visit, Ben asked the doctor, how come when I look in my clinical notes, because he asked to see them, I never see ME/CFS as a diagnosis that's put down. And one of the things he was told is, well, there's not a DIAG code for it that can be used for insurance and billing purposes. And I just think, just not even having a diagnosis that, and maybe that's correct or incorrect. I haven't actually verified that information, but I feel like it's not even something that's sort of well defined, even though it's, on the CDC has as a diagnosis. The fact that it's not something that's a billable diagnosis in the coding system seems a little bit like a barrier to getting accepted and used. So it's always being described as something else. So they have.
There is an ICD-9 that you can.
Okay. Well, so we need, that's why I said I haven't verified that, but that was what we were told. And it was like, oh, that just seems strange, Yeah.
Like I said, it's difficult for physicians that don't know that exists to just say, okay, I'm going to take responsibility of making this diagnosis. It's intimidating for the physician that doesn't understand the specific criteria or doesn't have familiarity with it. So that's part of why I think people don't code it or add it to the diagnoses, because it's just something that they're not comfortable diagnosing. And also we want to make sure that we're identifying the symptoms and ruling out other causes for similar symptoms. And I feel like this audience kind of, has a lot of suffering and has gone through a lot. But I just want to highlight that as physicians, when you present initially with fatigue, we want to make sure that this is not a new cancer diagnosis, or that there's nothing obvious that, that we can actually, take steps to treat it with pharmacotherapy that could be curative, right? So it's important for us to sometimes just go through the symptoms and make sure that the things that we understand and know how to treat and know that they respond well, like those are being ruled out. So that's part of it too. I feel like, it's a tough position to be in right now. But I don't want to defend, the whole institution of medicine, but definitely there are reasons why sometimes physicians will be hesitant and want to make sure that they're not missing out something else. Yeah.
So this next question is directed to both of you. So Dr. Azola, from your side, what kind of language can patients use to really get across like how exhausted, how tired, how limiting their symptoms are, that it's not just someone who's tired or who hasn't slept well, it's just like extreme symptoms that aren't just fatigue and tiredness? And then right. Dave and Sue, on your end, if you have any ideas for vocabulary that you use that really seem to get across to the physician how much was going on, I'd love to hear that from both of you.
In terms of the fatigue, yeah. So when people say fatigue, that can mean so many things. And I started seeing this population in the summer of 2020. And about a year after that, we had some meetings with researchers that were trying to work on post-COVID conditions research. And they were like, fatigue, but everybody gets fatigue. And I was like, no, this is not the same, just fatigue, right? I find that a lot of patients describe a heaviness, like a lead feeling in their body. That can be useful. Feeling like they have the flu, those type of descriptions, or exacerbation of specific symptoms. I give my patients an activity diary so that we can kind of pinpoint what is causing the exacerbation of symptoms. What's the temporal relationship? We know that it could be 24, 48 hours even after a particular activity or event or emotional situation. So I think that it's important for patients to tune in and give words. I know that there was a lot of comments about feeling unable to describe what they're experiencing, but I cannot underestimate the value and that information conveys versus somebody saying I'm fatigued. Actually explain, like, I feel like I have shards of glass stuck on my legs, for example. A couple of my patients tell me that. Those are things that are important to understand. For the physician, that it's just, it's not just fatigue, right?
Yeah, in our case, I feel like it just, when for better or worse, when Ben started to become really limited, that made it easier. This kid can't walk to the bathroom on his own anymore. That certainly gets people's attention. For those who, when Ben was less severe, yeah, it was really tough. Almost getting back to the previous point, I feel like, gosh, it would, it would be nice to, if there were more examples in the public consciousness to point to as a celebrity for us, but not in the wider world. Whitney Defoe is a celebrity for us, but not in the wider world. You might imagine that long COVID, there might be some natural spokespeople to come out of that, and just to get that public understanding. And then eventually, I think that can help in then working with whatever medical schools and hospital heads and things like that, just because it's more in people's consciousness. It's just hard to go from scratch when there aren't the examples out there. And we struggle that without ourselves, to be honest, for so long. It's just.
One thing I think was helpful is, we were able to describe some changes as an observer that happened. Maybe they weren't even aware of when they were in these states. Like, they had significant changes in the cadence of their voice, in the tone of voice, when they get really tired, like some of that brain fog, they may not notice that they're talking completely differently, but they sound completely different. And I think some of those types of observations are also sort of helpful, that may be harder as a patient to identify because you may not even be aware of it, but the people that are with you might have some observations, and that may also be helpful.
Presence of caregivers during the visit is key. Those visits can be really exhausting and cause a flare, and you may, kick into brain fog in the middle of it. And having somebody there who's going to be able to help get the message that the doctor is giving, as well as explaining to the physician what they're observing. It's definitely key. The other one that gets me, it's always like the washing their hair and showering. I feel like that one's very common. Like, it's impossible. Like, and some patients will be like kind of like scared to talk about it. But when I ask, it's just very telling of the level of symptoms that they're experiencing. Yeah.
Thank you for sharing your perspectives on that, both of you. This next question is for Dr. Azola. So physiatry is a medical specialty that I think it's not very well known to ME patients as maybe some other specialties that ME patients see, like immunology or infectious disease. So could you talk a little bit more about how that specialty might differ than others, and what kind of value it can bring to ME patients?
Right. So the specialty of physical medicine and rehabilitation is a specialty that looks at care of patients with significant impairments and disabilities, and helping them restore functionality. So our viewpoint is very much, or our training, it's mostly with communities such as stroke patients, spinal cord injury patients, traumatic brain injury patients, patients that had critical illness that cause significant musculoskeletal issues like critical illness myopathy. So we basically want to restore function. That's the goal of a physiatrist. So we understand the musculoskeletal system pretty well. We also understand in general the medical influences on function. For example, we have different subspecialties like cancer rehab, and where the cancer rehab doctors are trained on understanding what different chemotherapies cause to the body and how they can manage that. In the case of ME, I found, I really just stumbled into this field, and I understand that it's a really good match, and there's a lot of other physical medicine and rehab doctors that are starting to just jump into this field because we understand the value that we can bring to the patient care. I come from an institution where I have, Dr. Peter Rowe and Dr. Tae Chung from the POTS Clinic. They have, I can call them or email them and meet with them and help me kind of guide how to manage this patient. So I'm in a privileged position to be able to do that. But other people in other academic institutions have had the same experience and have taken the role in post-COVID clinics. And like I mentioned, we're kind of meeting and creating educational information for other people in our specialty on how to be able to best care for these patients. So it's a growing field, but we're not immunologists, we're not neurologists, although I would say neurology, it's pretty close, and we're kind of the functional aspect of neurological disorders. But yeah, we're kind of like general practitioners for people with severe impairments. Yeah.
Great. Thanks. Okay. I think both of you could answer this question. So when is the right time? Like, when do you know that this doctor is not working, and what kind of signs should you look for when deciding that you maybe need to look for another doctor?
I think for us, it's really been when they've given us complete misinformation and haven't been willing to sort of take in a different perspective. So, an example, we gave the GET example. We had another example where Ben had been progressing, and it was around the hospitalization, and one of the doctors who was actually the person who diagnosed Ben actually said, well, it's just really unusual for people to progress this way. This doesn't really happen. So it mustn't be ME/CFS. There's probably something else. And we certainly understand them wanting to look for something else that may be causing it, but the sort of notion that if you have ME, you couldn't have this type of a crash and become bedbound seemed to me like we were dealing with a physician that really didn't have a lot of experience and knowledge. And then especially, when the physician is looking at other resources, like papers and things about it that looking at the expertise to me, or consulting with folks that are experts. To me, that's been sort of a sign of, you have to have somebody who's willing to engage, because it is hard and you're not going to find someone who knows everything, but they have to be willing to know what they don't know and willing to try to help you figure out those answers elsewhere.
I think that, like I was mentioning before, the medical system, the way it's set up, there's incredible amount of burden of burnout, compassion fatigue. It's difficult when you're not able to make your patient feel better or become more functional. You can jump into avoidance behaviors like I was describing before. And I think as a patient, I would say, understand that the physician is also a human, and they have their own issues, and it may not be personal. It may speak more of their issues with struggling. It's complex, and I think that in order for patients with chronic illnesses, chronic fatiguing illnesses, to be able to receive care that's comprehensive, you really need to find a person where you can create that relationship and you can have the flow of information, and you're able to work on that relationship, both sides. If the physician is not engaging on that relationship, then that's not a good fit, right? You need to have both sides contributing so that you can create that agreement between the two parts. And the patients, it depends on personal issues too, and historical issues. It's a tough situation. I'm just reading the comments on the chat. It's a little bit overwhelming because it's tough, right? As a patient, that is suffering, that is having severe impairments, that their lives has completely gone upside down and they're not able to be themselves, right? Or what they were, and trying to look for answers in physicians. And sometimes, on my better days, my best is not enough. And I just have to kind of live with that. My best is not enough. So it's something that the physician has to be okay with. And sometimes that can be difficult for a physician.
Yeah. Thank you for sharing that. Okay, one other question that we have here is, this one's kind of for patients who may have been sick a really long time. So maybe if you just got sick and you go to the doctor, you have kind of a short window of time where you have your history that you're sharing. But for patients who have been sick for 15 years or 20 years and they go to a new doctor, what kind of pieces of information does the doctor want to know when there's so much that could be contributing to the illness over those years?
I think that it's important for those patients, when they're seeing this doctor, what is specifically their top three in that moment? What are the targets? What is really their main impairments? And then as the relationship forms and grows and continues to have visits, you'll continue to learn more of the information. And I think sometimes it's useful. I know this is hard to create the list and kind of a chronological order. It is difficult when you have brain fog and when you're experiencing severe fatigue, but if a caregiver or anyone can help you do that, that's really helpful. And your doctor may not be able to read it at that moment, but when they're looking over your files later, or, you know, they can revisit that. And if it's in bullet points, it's really helpful to give you context. So I think trying to target those top things that are bothering them in that moment is important. And then, you know, kind of giving that information in a summarized form can be helpful, because sometimes we have an hour and you're going through, you know, 10, 20 years of history with so much pain, so much attached to it, right? And it can be overwhelming, and the physician may feel like, I don't know how I can help you. You know, like it just feels too overwhelming. So I think always summarizing it to those top 3 things that we can target is important.
Yeah, thanks. So I think we're gonna wrap up this question and answer session, but I just have one final question, and this one's for Dr. Azola. So, you know, it sounds like from what you've shared with us, you came into this field with COVID and started to see these long COVID patients, and you came to this field as well as some of your colleagues. And so reflecting on that, like what do you think it's going to take to get other providers to get attracted to this field and want to serve patients with these kind of chronic complex illnesses?
So it's going to take a lot of education. It's going to take a lot of policy change. It's going to take a lot of frame of mind. It's going to take a lot of research to better understand the pathophysiologic mechanisms. Because the fact that this type of disorders have been so neglected by funding for research, et cetera, has caused a gap in the knowledge, and the science is very much behind. So I'm hopeful that this pandemic, you know, brings a surge and on research that can really solidify understanding of the pathophysiology of it. I think right now, and I'm going to be completely transparent, you know, at an institution level where I'm working, I can see the differences in opinion in some of these more obscure illnesses, right? And it's because of the lack of science behind it. And I know that that's not the patient's fault, but I'm hopeful, like I said, because of the surgence of this mass disabling event that is the pandemic, this will bring more light into that, and we'll be able to, 1, educate providers, and 2, bring legislature and more of a clear understanding of the accommodations and benefits that these patients need in order to be taken care of. Yeah.
Mm-hmm. Mm-hmm. Yeah, and I see that Dave and Sue also added in the chat too that treating illnesses like ME/CFS or long COVID they could take a lot of time that physicians don't always have, especially when we have fairly short appointments where not everything may be covered at once, and it may take a long time to get at the root of different things and try to treat them. So maybe, so one idea it looks like that they have is to allow physicians to have more time to see these kinds of patients where more time is required.
It takes so much time. It takes so many emails. We're so taxed already. You know, it's definitely, my experience creating this clinic has been that providers that were initially interested have stopped seeing patients in the clinic because they just find it difficult. So I find that most people have to have some sort of investment in the cost. So we see a lot of either providers that have family with these issues or have issues themselves that have an engagement and a more of a cost, right? Fight for the cost that are more engaged. But it's certainly it's certainly a lot of ground to cover, but I think that the future at this point looks a little bit brighter because of the new population of this mass disabling event.
Yeah, yeah. So I just want to thank you all again for your time this afternoon, coming to speak with us. Dr. Azola, for sharing your perspective as the provider, and again, Dave and Sue, for sharing your family's experience. And I really appreciated hearing that, because I could relate to a lot of aspects of that story too. So thank you for sharing. I just want to end our session with a few reminders about what's coming up. So we are going to have our next conversation in May, and that topic is going to be all about fibromyalgia. So the next date is going to be May 15th. Again, it's going to be 4 p.m. Eastern time. And our featured speaker will be Dr. Paul Monach, who is the chief of the rheumatology section in the Boston VA healthcare system. And he's an associate professor at Harvard Medical School. So this is going to be our first conversation dedicated to the topic of fibromyalgia this year. So I hope you can join us for that session. Also, if you have ideas for future programs or speakers, please do email us at events@massmecfs.org. We do want to hear what kind of presentations would be interesting to you, so we're willing to take those thoughts. The Sunday conversations are meant to be a program that will provide a variety of practical information that patients and families would need and want. So also, if you would like to join our Sunday conversations team, you can as well. So you can email volunteer@massmecfs.org. And we're working on the fall schedule right now, so let us know. And finally, if you found this program worthwhile, there are a few ways you can help. You may make a donation to help support this series by donating online at massmecfs.org/donate. On the same page, you can sign up for a newsletter, and if you donate $25 or more and check Become a Member option, that will establish or renew your membership, and you will be invited to our members-only programs. Thank you all for coming, and we hope to see you again next month.